All right, what's up, Mark's team? We are going to be recording potentially a two-parter. I'll keep time here and we'll try to keep it to a 20-minute episode. And this is going to be for surgical Saturdays or whatever Mark would like to call these. It's just kind of reigniting something that we had done in the past pretty frequently. And the goal is to get these out weekly on Saturdays. And we're going to record an excess amount of these and send them all your way with the hope of getting these out on a weekly basis. And yeah, and Dr. Briskie, anything to kind of add um, to the prequel?
To the prequel? Not really. I mean, it might be a two-parter, this one.
Okay.
It's kind of more of like like rehearsing for a Neodent, the Neodent one, right?
Yep. And so title of this one is how to, I guess, drilling protocols, how to never have a spinner again. Okay. How to always obtain stability. Some version of that, whatever title Mark kind of wants to work with it. And we're going to be giving this speech at the Neodent Symposium in San Diego. Mark is also going to be on the main stage talking about Dental Success Institute at Neodent. And I think it's the first time he's talking in front of that crowd, which will be a pretty cool experience as well. And so, however, Mark wants to kind of promote this one and get on and do the intro for this podcast is obviously he's a seasoned vet. So let's go ahead and get started. And hopefully we'll keep it to 20 minutes per episode and we'll do a two-parter in about 40 minutes. All right, welcome everybody to another episode of Surgical Saturdays. I am Dr. Taher Dhoon, and I have Dr. Daniel Briskie here from Colorado Surgical Institute. And today we're going to be talking about drilling protocols and how to never get a spinner again. So, Dr. Briskie, what does that mean to you and how you do your drilling protocols, and how do you always get stability?
So, very big question, right? So there's a lot of ways that we can go with this discussion. I think some of my goals though are like how do you consistently achieve primary stability of your implants, whether it's single or full arch, right? I think in the beginning you really need to focus on the feel of the bone and observing the bone flutes. Like what does the bone look like, right? Do you have D1, D2, D3, D4 bone? It's drilling is not simply you drill in and drill out. I think as you develop a sixth sense for implants, you start to really feel the bone in a way. And what I want to do is accomplish uh, helping everyone learn Colorado Surgical Institute's drilling protocol. So, and how you achieve best practices. And best practices for Colorado Surgical Institute, it means that we are achieving 45 Newton centimeters on all of our implants. Because if you have 45 Newton centimeters, right, you can do anything with the implant at any point in time of healing. And I know that sounds funny for everyone listening. Like, what do you mean you can do anything with it? It means that the implant is so stable that you could actually take out the cover screw if an incision opens and putting healing abutment on it, right? Or you could switch a multi-unit, or you could do so many different things with the implant to help save it and nurse it along without accidentally backing the implant out and holding it in your hand.
And at 45, would you feel comfortable at doing it like an immediate load?
Yes, 100%. I think 35, I would feel comfortable with immediate load. But again, I think I really truly believe that we can get 45 Newton centimeters on every case.
Okay. And so let's start with the premise that we are agnostic to every implant system out there, any, materials you want to use. I mean, whatever works in your hands, use them. We're going to talk about what we do over here. And so we're going to talk about the Neodent implant and the placement with the Neodent kit, primarily because it's what we use in our private practices, it's what we teach. And the way the implant is designed, the bottom half of the implant is like a triangular, thread. So it's like a self-tapping cutting thread. It will pull the implant down into the osteotomy. And then the second half of the implant is a trapezoidal thread. So it's a compressive thread. So then once half the implant is in the osteotomy, then the second half, you start to get a lot of torque. You get a lot of pressure and it's condensing the bone. And so utilizing a good drilling protocol with this specific implant and the fact that it has a deep conical connection for all its prosthetic parts it lends itself to a lot of stability and a lot of like user-friendly type of approaches. So you can use it in your single implants, you can use it in full arch, you can use it for overdentures, and you don't have to necessarily switch out your systems. You can use it for zygomas, you can use it for pterygoids. And so that's what we do in our own private practices and at the educational facility at CSI.
I
I guess
like
what,
that.
yeah,
Yeah, what Dune is basically saying is he's painting a picture of what the ideal implant system looks like for him, right? Like what are the key things that he's looking for in a system, and the reason that we are placing Neodent, or there are actually some other good systems out there too, right? That I wouldn't mind placing. But the things I would look for are something with platform switch, obviously, right? It has internally indexed. It has a conical connection. Conical connection means that it causes a cold weld. So the conical connection needs to be less than 20 degrees. So versatile, meaning it can be used in singles and multiples and full arch, or you got some narrow ones, you got some zygos and pterygoids, right? You just want something to really fix everything so you can have least amount of systems in your practice. So you want something narrow diameter, like 3 millimeters, or even wide, like 7 millimeters. It needs to have a very aggressive taper design. I think being Nobel compatible helps a lot because you can buy parts from third parties and put those on your implant without having to spend so much money, and cost too, right? Like I don't want to spend $250 on an implant. I'd like to spend, a buck 60 or under. I think would be pretty nice.
yeah, yeah. And so you just checked everything off the list on that end. So let's assume we're going to place single implants in this example, and it's in a ridge where we don't know the density of the bone. We've looked at our CBCT, and we think it's going to be D2, D3, but for whatever reason, let's say we're going in blind and we don't 100% know, and we're going to evaluate the density of the bone based on tactile sensation. And so make your decision wherever you make it. That's not going to be the context of today's podcast. There's many different philosophies on how you make incisions in implant surgeries. And that, excuse me, Dr. Briskie, what's the first drill that you're going to use?
The first drill I like to use is a 1.5 millimeter lance. I call it my precision burr. So it's actually really tiny. So 1.5 is definitely smaller than a 2.0, but if you hold them up next to each other, it looks like 50% of the size. So I like to drill with a very sharp burr in as smallest one I can find, because you want to be able to change your angulation. Because if you drill with a 2.0 and you try to change your angle, now you're already at like a 3, right? Or a 3.5. But if you start out at a 1.5 and you drill a small hole, you can have the ability to change the angle better, or more times without having to worry about decreasing the stability of your implant.
Yeah, and having the ability to change your angulation when placing singles is actually pretty important. Sometimes the roots of the adjacent teeth are just, they diverge and converge within your space. I was helping out my associate the other day, and it looked like she showed me like the position of the guide pin looked perfect. We took an X-ray, and we're actually heading a little bit towards the distal root. So we re-angulated everything and all of that worked out fine, but it's getting that check PA. So what I like to do is we get that 1.5 lance burr. Now this does not come in the Neodent kit. We order them from Blue Sky Bio, or you can find them other places too. They're just a very sharp lance burr that I stock in each one of my surgical kits. And I'll take it in just till I pierce the cortical plate, and then I'll stop drilling and I'll push. And I'll push with enough pressure to just, kick the patient's head back just a little bit. If the patient's not sedated, I tell them like, hey, I'm going to put a little bit of pressure here, hang tight, and I push. If the drill is going to advance without any type of rotation, then you're in softer bone. And then, well, what's the density? It's most likely D4. Do you think when you push Dr. Briskie with a 1.5 that it could potentially be D3, or not really? It's more D4.
Yeah, I think if you just break the cortex, right, what you just said, and you go in 3 millimeters, now you're able to feel where you are, right? And I think D3, I don't know if I say D4, you could push the lance in. I'd probably argue that you couldn't push the D3 in.
Okay. So let's say your lance burr it advances, you're in D4 bone. So automatically you're going to see, well, can I push my drill to depth? And if you can, great. Well, grab your next drill and don't rotate it, just push. And if you can push that to depth, because that's your 2.0 drill, then great, grab your 3.5. and you might have to just rotate it a little bit to pierce the cortical plate and then stop and then push it again. And if it pushes all the way to depth, okay, you're definitely in D4 bone. And then you might be talking about changing your implant up to something like a drive implant. So Neodent also has a helix implant that we primarily place that has the design we talked about in the beginning. And it has a drive implant that has only trapezoidal threads. And it's made for soft bone protocols. And at the same time, it has the same platform. So every part and piece you use in your practice fits it the same, and you don't need to stock any other inventory. So in that situation, if I'm pushing in a 3.5 to depth and I'm not rotating anything at all, I'm automatically thinking about a drive implant. And then just, and Dr. Briskie, I mean, this can be a fluid conversation on this next question I'm going to pose to you. But do you ever use like Versa burrs or even just take the Neodent burrs and run them in reverse? So then you're kind of, instead of the flutes are cutting, you're actually just, making the bone more dense as you push these drills in. Is there any benefit to doing an approach that way?
So I do have my thoughts on this one. So I think in D1, D2, or D3 bone cases, I really truly believe that if you just undersize your burr like by one and you feel what the bone is, you have absolutely no need for a Versa burr, right? And a lot of the cases for D4, if you can press the burr in, right, how much good is a Versa burr going to be doing at condensing the bone into like a D3? I really don't think it will, in my experience, because I've had cases where I would just push an osteotome in that's like a 2. Like I pierce the plate like 3 millimeters, right? Just pierce it. And then I push an osteotome in that's a 2.0. And then you throw a 3 by 13 and implant it, right? And it still gets like a 30 Newton centimeters. So I think in those cases where it is so soft that you can't even get stability by pushing something in and then putting an implant in, I think a Versa burr will be useless. So in those types of cases, I think you have to engage bicortical, which would mean you have to engage the bottom of the nose in order to actually get stability on the implant. So I think a lot of docs, I get a little bit worried about Versa. I think it's a good tool to know how to use, but I do see some docs getting in trouble by trying to condense bone that maybe we don't need to be condensing, and then we're burning bone, right? And the worst thing that could happen is a catastrophic failure with a Versa burr, because if you burn that bone, that whole site is just cooked later, and you can't use that entire site now. So for myself, I feel safer understanding what bone feels like and how to undersize my osteotomy rather than rely on a burr to try to increase density for me.
Okay. Yeah. I would agree with all of that. And I would say if you already own the Versa burrs, then use it in D4 cases and maybe in immediate molars where you run it backwards and then it pushes bone into where the, sockets were type of thing. So you're kind of like pushing autogenous bone into the sockets when you use your Versa in reverse. But either way, it's few and far between that I actually will end up using them because of the advances in this drilling protocol we're going to go talk about, as well as the advances in some of these implants and how they can obtain stability based on their design. So that's really D4 bone. And then you place your implant, of course, and see what your stability is. Maybe the only other caveat I would say on D4 bone is you can go for bicortical that Dr. Briskie talked about, engaging the base of the sinus or the base of the nose, or you do not put your implant subcrestal. And so the reason why is the crest of the ridge is a cortical plate. And so most implants, or at least the Neodent implant, wants you to go 2 millimeters subcrestal. Well, if you go 2 millimeters subcrestal, you're not engaging cortical bone at the crest. And so what you may find is your stability goes down from a 35, and then you start to see it go to 30, then you start to see it go to 20. As you go further and further down, what that means is that it's the cortical bone at the crest of the ridge was giving you your stability, and you should stop. And you should stop and allow the crest of the ridge to maintain stability for the implant as it integrates and sacrifice on some emergence profile and some of the other benefits of a 2 millimeter subcrestal placement.
So if everyone didn't hear that, I want to, this is really important. So pause it and rewind this like 2 minutes, because what Dr. Dhoon said is actually really, really important. And I have so many examples of this, even within the last 2 weeks. So I'm going to go over what Dune is saying just one more time for everyone. I'm going to picture it in a case that I just had 2 days ago. So I had an upper and a lower arch. And when I looked at the CT, you look at the CT and the CT looks dark, right? You see the cortical bone, so you see a white eggshell, but the inside is just dark. It looks like a giant hole, right? And you're like, oh man, this case is going to be fun, right? So what I did was, right, took out the teeth. I did my reduction like normal. And then when came time to place in the implants, right, I planned it on my CT, so I know where my entry point's going to be. And I drilled a hole down with a 1.5 lance. I took an X-ray, make sure that I like where I am around the sinus, and this is going to be for an all-on-4. So I'm at my distal implant right now, right where number 5 is. So I pierced the cortical cortex, right, and then I pushed the burr in. And then at that point, I took an X-ray, make sure I like where I am. If not, then you're going to change that slightly with your 2.0. And then at that point, all I did was I took a 3.5 millimeter burr, and just with the first 2 millimeters, I defined where I want to be on the top of the ridge. So I wanted to make sure I'm more lingualized. So I made a tiny little indentation on the bone, right where the lingual plate is. So my implant will follow that position. And I put a 4x13 in, right? So I went from a 2.0 hole to a 4x13, 4.3x13 implant. Now I got a stability of 30 on that one, but I'm thinking, man, am I really okay with the 30? And I was like, no, I really am not. So I'd rather back that out. My goal is 45. So if we're going to allow this implant to heal, and during the healing process, that you're going to want to take the prosthetic on and off, you're going to want to make sure things are healing well, right? So for me, I'm going to want to make sure all my implants are at 45. So I took the 4.3x13 out and I put a 5x13 in. And then I actually got 45. So I was like, ooh, cool, right? I was actually able to get my stability. Now, if I did put that in and I was able to still get 30, I would have actually went to a longer and wider implant again. So I would have grabbed a 5x16 and I would have grabbed a more aggressive implant. So Neodent has two implants. They have a helix and a drive, and the drive implant helps condense bone. So I would have not only grabbed a longer implant, but I would have grabbed a more aggressive one. Now, in that same case, it was actually different on the bottom. The bottom was actually softer than the top. And I only had two 5x16 drives in my closet. I had like this giant closet with all these implants, and I only had two of those. So I was like, oh, I don't want to use it on the top if I might need to use it on the bottom. So bottom was about the same. I drilled a 1.5, and then I pushed a 2, and then I put a 5x13 drive implant in. And on that one, I was able to get 45 Newton centimeters. But the only reason I was able to get 45 is what Dune said before, which is while I'm torquing my implant down, I'm looking at the cortex portion and I'm making sure that my implant is about 1 millimeter subcrestal, but it's still engaging the cortical plate at the top of the bone. But the moment that that goes below the cortical plate portion, you lose stability. So you have to really gently like work the implant down. And while you're working it down, you have to use that side of the torque wrench where you can actually see the exact stability. And the moment that you notice that dropping at all, right? So if it's at 45 and it drops down to 40, I would just stop at that point. Because if you try to take it lower, you're probably going to end up with a spinner. And now you can't load the case.
Yeah, and that's D4 bone is very rare, very, very rare. But usually speaking, you'll be able to pick it out on your CBCT based on the way that Dr. Briskie just discussed it, right? It's a egg white shell of cortical plate. Doesn't matter about the thickness of the cortical bone. Sometimes it's really, really thick. Sometimes it's really, really thin. Typically elderly females, it's going to be really, really thin. And then, some males, you're going to see like a really thick cortical plate, but a lot of trabecular space that's all just soft. So all things you're going to see over time, and you're going to start to like make mental notes when you start to run into stability problems. So with all that said, that's D4 bone. So let's go ahead and now briefly just kind of finish up the D4 component And then on the next episode, we're going to go ahead and cover your D2, your D3, and your D1 protocols in terms of how you handle drilling in those scenarios, because those scenarios you're going to run into a little bit more often than not. So Dr. Briskie, any other thing with D4 in terms of the drilling protocols or anything else to be kind of aware of in the last like 30 seconds or so for this
Yeah.
episode?
Yes, definitely. It's so important to realize if you're in D4 bone or not. I think a lot of time as doctors, we we may have a not stable implant and we say, oh, the bone was D4. But I want us to all focus on really knowing the difference between D4 bone and something that's D1 to D3. Because the main reason we don't get stability is we're over drilling, right? So I think if we stop over drilling and we start to increase our knowledge of what the bone feels like, I think we can actually spot a true D4 bone case. So we're not just calling, a soft bone a D4 every single time an implant doesn't get to its stability, right? So I just want to encourage everyone to just be really humble. Implants, it's a big journey. It's not easy to figure out, but I think you can get to the more experienced level a little quicker if we're just humble and honest with ourselves and really just focus on spotting these issues before they pop up.
Yeah, and what I would say also to confirm if it's D4 is when you take out your drill, let's say you did actually have any type of rotational movement on the drills. If you look at the drills and you see physical bone inside the flutes, then typically that's a D3, D2. D2 you'll see white bone in there. D3 you'll see all only red bone. And D4, typically speaking, you mainly just see blood and like a little bit of bone. It's like a spongy looking type of thing. It like just looks really, really soft. So if you just don't see any bone on the drill and you've rotated it, you're most likely in D4 bone and it's an accurate diagnosis on that end. But like we were saying, it's rare to be caught off guard with D4 because of the use of CBCTs and that push protocol, drill like 3 millimeters in and push and see how far you sink. So just being prepared for that's going to be important. So what we're going to do is we are going to wrap this episode up and we are going to come back to you guys and talk about more D2 and D3 and D1 on the next episode. And then feel free to reach out to us at coloradosurgicalinstitute.com. You can find Dr. Briskie and myself on Facebook, on Instagram. Feel free to message us. We're on Dental Success Network and we're faculty on those forums as well. Reach out to us with any questions or anything that you need us for on anything surgical. Quite frankly, I mean, we do crown and bridge and all the dental stuff too. So if you got questions there, we're more than happy to help. And we're going to be here providing a lot of content, hopefully every Saturday for you guys. And we're out. Okay, cool. So I'm going to stop the recording here.
Yeah.